So these slides I've adapted from my counterpart at Northwestern, Lisa Kinsley. Some of us may know her here. She's another fantastic genetic counselor. She could not be here today, unfortunately. But these are Lisa's slides originally, so appreciate her letting me use them. We have no disclosures. I wanted to start with a little bit about genetic counseling. Who here has met with a genetic counselor? Yeah, a good amount of people. Okay. And how many of us know what genetic counselors do or who we are? Okay, good number of people. That's good. Um, so who are genetic counselors? We're healthcare professionals with specialized graduate degrees and experience working in medical genetics and counseling, psychosocial counseling. We oftentimes work as members of interdisciplinary care teams. Alongside many of the other great individuals that are giving talks here today that are in this room. We provide information and support to families who have members with birth defects or genetic disorders, and to families who may be at risk for a variety of inherited conditions as well. So as you can imagine, this spans a lot of different areas. We work in neuro, we work in cardio, we work in peds, prenatal, maternal fetal medicine, cancer, list goes on and grows every day. We also act as resources for other healthcare professionals and for the general public. Many genetic counselors engage in research activities related to the field that we're working in, and overall just medical genetics as well, and or genetic counseling. I can say for myself, I've been involved in a number of research studies in my time at Rush, which has been very exciting. So what is genetic counseling? Genetic counseling in and of itself is the process of helping people understand and adapt to the medical, psychological, sometimes we call these psychosocial and familial implications of genetic contributions to disease, which if that sounds complex, I would say it very much is. This process integrates a number of different areas that includes interpretation of medical and family histories to assess the chance of disease occurrence or recurrence, education about inheritance, testing, management, prevention, resources, and research. And then again, counseling to promote informed decision-making and choices, adaptation to risk or the genetic condition itself. Genetic counseling and training involves a master's degree, master's of science usually, in genetic counseling, usually a 2 to 3 year program. And we have training in medical genetics and psychosocial counseling. So this helps guide and support patients seeking more information about how genetic diseases and conditions might affect them or their relatives. We also interpret genetic test results. So we're kind of there for the entire process, going through from the beginning, making an informed decision again about whether we're ordering genetic testing or not. If we are ordering genetic testing, what test is that? And then once we get results back from the laboratory, what do these mean for us? Not just for the person getting tested, but for other people and their family as well. Some of the basic session components of genetic counseling, and every session is a little bit different, right? So these sometimes can vary and shift depending on the indication, depending on who we're seeing. But we oftentimes will be obtaining family histories. We'll be giving information about Huntington, specifically in an HD genetic counseling session, explaining the genetics of Huntington's disease, discussing motivations for genetic testing, exploring the person's experience with HD, which can be informed by a lot of different things, oftentimes their experience with their own family, right? Discussing the timing of testing, so like turnaround time, how long does it take to get results? How long is this process gonna take from start to finish? The testing process logistics, including insurance coverage, collection of the DNA sample itself, blood versus saliva versus sometimes we can accept cheek swabs, and then also review of protections for employment and insurance discrimination. There are some federal laws now and some state-based laws that help protect against genetic discrimination. I gave a talk about this at our HDSA symposium last year. If anyone went to Rush's, feel free to ask me after this. And then also results disclosure. So again, sort of discussing what do these genetic test results mean once we get them back from the laboratory. So I'll go through this genetics refresher here maybe a little bit more quickly because I think Dr. Hall and Dr. Bega gave a really great refresher earlier in their talk. And I think a lot of us probably already know at least some of the basics here, but always good to have a little bit of a re-review. Our entire body is made up of cells, right? So cells of all different types, skin cells, muscle cells, brain cells, bone cells, on and on and on. All of our cells contain our DNA in the center part that we call the nucleus. And here we see the chromosomes, right? So chromosomes are basically just bundles of DNA that are bound together in these X-shaped structures. They come in pairs because we get half our set from mom and the other half from dad, right? So as you can see here, I sort of like to call this a mug shot of the chromosomes lined up side by side together. We have 23 pairs of chromosomes. And again, for each one of these numbers, we get one from mom, one from dad, all the way down the line here. This picture shows a male, what we call karyotype. So a biological male, what their chromosomes look like, because the very last pair, the 23rd pair, shows an X and a Y, one X and one Y. Here we see female chromosomes because there's two X's and zero Ys. This is really just to orient us that that final pair of chromosomes called the sex chromosomes actually doesn't play a role in Huntington's. As it turns out, I think I have a slide on this coming up, but the Huntington's gene is located on chromosome number 4. So the fourth pair up at the very top, that's where the Huntington's gene is found. When we unravel the DNA from that chromosome, we find that Huntington's gene in each of those chromosome number 4s up there. So what is a gene? A gene is basically a section or segment of the DNA that, again, is wrapped up into these chromosomes. I sort of like to think of them as books on a bookshelf, and then that sort of makes the chromosome itself a bookshelf, right? A bookshelf that contains hundreds of different genes within it, right? And so a gene is just, again, quite literally a piece of DNA that is part of a chromosome. And there are different genes that relate to different cells, different functions with regards to our health and our body. So, again, going back to the fact that our entire body is made up of cells of all different types, right? Bone cells, pancreas cells, brain cells. There are different genes, again, sort of different books in our library, if you will, that give information to the cells in that part of the body, how that part of the body is supposed to be built, how it functions, how it works, kind of baseline operations. It's sort of like genes for like the For Dummies books, right? Like Bones for Dummies, Pancreas for Dummies, Brains for Dummies, right? And it sort of just tells all of our cells, how is that body part, how is that organ normally meant to work, right? So then looking a little bit more closely at the structure of DNA itself, it's made up of these building block letters. We call them nucleotides. Don't expect anyone to remember that. Very big word, but nucleotides are basically our genetic alphabet. You can see here it's made up of 4 different letters, A, T, G, and C. And these just represent the chemical compounds that, again, are essentially like the building blocks that make up our DNA, the fabric of our genetic code. So they are really similar to, when you think about typing out a Word document, right? It all starts with putting together letters, and those words or those letters build words. Those words build sentences and paragraphs, right? It all starts here with these letters. And when we're running genetic testing, what we're looking to see is, are the letters correctly spelled? Are they in the right places? Are they in the correct quantities? Are there too few or too many of certain letters in certain places? We're basically running a spell check on the DNA, making sure that all of the letters are correctly spelled throughout our DNA. And if there are any what we call genetic mutations, I think a lot of us are familiar with that word, right? But a genetic mutation is really like a genetic spelling error or typo in the DNA that sort of gets a little red squiggly line underneath it in the Word document. So it points out this may not be spelled correctly. Again, I think going back to Dr. Hall and Dr. Bega's talk, they mentioned earlier that genes really provide instructions for making proteins. Sort of going to go past this a little bit more quickly, but kind of take-home message here is that when there is a genetic mutation, a genetic spelling error or typo, it's almost like an issue with the assembly line, the production line of taking the gene, the instructions for how to build that protein. The protein doesn't turn out the way that it's normally supposed to, right? It's almost like if you have a recipe to make a cake and it calls for 3 eggs and instead you add 30 eggs, right? That's probably going to be more like an omelet, something like that, right? So you're basically looking at the recipe, making sure that all of the instructions for how to make the cake are actually written correctly in there, right? So let's talk about the inheritance for Huntington's. I think, again, probably a lot of us already know some of this information here, so I'll go through this a little bit more quickly here too, but I mentioned before that the Huntington's gene that we call HTT is located on chromosome number 4. When someone has a genetic mutation, there's going to be a 50% chance. We're going to talk about that in a minute here, but this can come from either a genetic mutation in an egg cell or a sperm cell, right? And then once egg and sperm meet and the egg is fertilized, that's what ultimately divides into all these other cells that become somebody's body, right? This is starting from the very beginning, from when we're an embryo, right? But this fertilized egg is ultimately what gives way to reproductive cells, bone cells, pancreas cells, brain cells, right? So this genetic mutation, if it comes from either the egg or the sperm, is going to be passed around to all of the cells that make up that person's body, ultimately, right? And then an important concept in Huntington's genetics is DNA expansions, what we call trinucleotide or triplet repeat expansions. This refers to the fact that, for one, the code of our DNA kind of comes in sets of 3 letters. 3 letters translate to one building block in the protein. So any given 3 letters of the alphabet letters that make up the DNA, any 3 letters that we put together is going to give some ingredient to put into the protein, right? So here, sorry, there's a lot of transitions in these slides. Okay, so you can kind of see here that again, these triplets translate to, I like that Lisa sort of color coded them here, but a different, what we call amino acid within the protein over on the right. So the little wormy looking structure on the right is meant to represent the protein, and each one of those beads that's added to the protein is called an amino acid. It's an ingredient, a building block for the protein, and that comes from a set of 3 letters in the DNA code. So we'll get back to that in a minute as well. But dominant inheritance means that both males and females can be affected with Huntington's, and they can also equally pass it down to their children. If a person has Huntington's, there's going to be a 50-50 chance of passing it down to every child that person has. So if a father has Huntington's disease, or he's gene positive, maybe I'll say, there's going to be a 50% chance that he passes down the copy with the expanded number of the CAG repeats, right? And then a 50% chance that he passes down the normal sized copy. If a person does not inherit Huntington's from their affected parent, their gene positive parent, they can't pass it down to their children. You can't pass down something that you yourself don't have. And then if each child, each child of a person with Huntington's has an independent 50% chance. So that means that you're not going to be impacted. Your risk of Huntington's is not going to be impacted by how many of your siblings, how many other people in your generation of the family tree have inherited Huntington's. Even though I think in our hearts, it might feel like, if we're from a family of 10 people, 8 of our siblings have tested positive for Huntington's, we might be thinking, I'm going to test positive too, right? It just seems like everybody's testing positive. In reality, everybody has their own independent 50% chance, and it's not influenced by how many other people have tested positive or negative. But this is sort of, I like this visual. It sort of gives a breakdown of the autosomal dominant inheritance pattern, how these genes pass down. In this picture, the purple strip represents the mutation, right? So we see here that, let's say this is the father over on the left side that has a genetic mutation represented by the purple strip. There's going to be basically kind of like flipping a coin, heads versus tails, right? Where, one of those blue copies is the head, the other blue copy with the purple strip, the mutation, is the tails, right? So there's going to be a 50% chance that the father is going to pass down the blue copy on the left, but also a 50% chance that the father passes down the blue copy with the purple mutation on the right to each of these children at the bottom here. Yep. And so here we see that, roughly 50% of the children will be expected to inherit the genetic mutation and be affected. The other 50% will inherit the quote unquote normal copy and be unaffected. Genetic counselors love to draw pedigrees. Has anyone seen a pedigree before? Does this look familiar to anyone? Yeah, some of us. Yeah, awesome. So we use these. I kind of like to call them visual roadmaps of family histories, right? They're kind of like picture representations of our family tree where we use shapes to represent the individuals and lines represent the relationships in the family. So squares represent males, circles represent females. Diamonds sometimes represent either a combination of males and females grouped together, or if we don't know the biological sex of somebody, we might use a diamond. But then again, the lines demonstrate the family relationship. So higher up on the pedigree is older generations. So at the very top, we have a grandfather and a grandmother. Further down is younger generations, right? So we have a parent, and then all the way down there, we have children. This is a very typical pedigree for Huntington's disease because we know that it's a dominant condition that passes generation to generation in the family, right? I probably don't need to explain that to most people in the room here, but Huntington's does normally travel from, say, a grandparent to a parent to a child, right? It goes from one branch of the family tree to the next in an unbroken line. There are sometimes odd exceptions to that rule, but for the most part, it usually travels from one generation to the next in the family tree. A little bit about Huntington's from a clinical standpoint. The onset can range really throughout the lifetime, although most typically symptoms will start presenting in your 30s or 40s, but there can certainly be a lot of variation there. We estimate that about 6% of Huntington's cases present before the age of 20, which is defined as juvenile onset Huntington's, and the prevalence is estimated to be about 7 to 10 per 100,000, but that's probably an underestimate. There's probably a lot of people that have either been never diagnosed or misdiagnosed with something else. We know that there's about a 15 to 20 year duration from the onset of symptoms as well. There's also this concept in Huntington's called anticipation, which refers to the fact that the CAG repeats in the gene, right? Those CAG triplets that cause the expanded genetic mutation, they can grow bigger in number when passing from a parent to a child. So expansions occur more often with paternal transmission. So when an expanded number of repeats is coming from a father, it's more likely than when it's coming from a mother that number is going to grow into a bigger size. So that may result in younger ages of onset. It may even result in a parent being in a lower CAG size that maybe doesn't even cause Huntington's. They pass down a bigger size to the child, and the child is the first person in the family that has Huntington's now. So again, some of those special exception cases we'll talk about here a little bit more in a minute. Also, expansions tend to occur more often with larger repeat sizes. So when you already start with a bigger repeat size, it's going to be more likely that we see anticipation into a bigger range. So let's talk about genetic testing a little bit. I'm not going to go through all of these here, but feel free to take a look in your packets at sort of the timeline of some of the research updates with regards to Huntington's. But starting in 1872, taking us all the way back, George Huntington published a paper on Huntington's. Mendel's work in 1900 was rediscovered. He was a major player in the field of genetics. And then we have Punnett citing Huntington's disease as an autosomal dominant disorder. We just talked about that in 1908. In 1983, the Huntington's gene is mapped to the short arm of chromosome 4. So we looked at that, again, that picture of chromosomes before. In 1983, we're sort of, the metal detector is getting louder. It's starting to beat more rapidly. We've isolated the Huntington's gene to the chromosome that it's on, but we're still searching for the piece of DNA, the gene itself. In 1993, we finally strike gold, so to speak. We find the Huntington's gene that's called HTT, that's located on, again, the 4th chromosome, the short arm, and we identify that there is a CAG triplet repeat expansion that causes Huntington's disease. So this is really the first year that genetic testing is kind of widely made available in a clinical basis for Huntington's. From there, starting in 1994, we have a working group on HG that publishes guidelines regarding counseling, genetic counseling for predictive testing for Huntington's. So this is really where our current HDSA genetic testing protocol comes from. As Tyler mentioned too, I sit on a work group for this committee where we're trying to update and revise the guidelines from the most recent, I think, 2015 or 2016 version. So the HDSA tries to do that every several years just to keep up with changes in Huntington's genetic counseling and genetic testing protocols. And then the testing process itself is done on blood samples most often, but nowadays I'll sort of amend this and say that we can sometimes perform it on saliva or cheek swab samples. There are laboratories that do accept that. At Rush, we perform our testing in-house, and we always collect a blood sample. But genetic testing in general can be done on other types of DNA samples as well. But blood, I think, is probably one of the more common ones. This is also, the second point has changed a little bit, usually ordered by physicians. Dr. Hall orders all of our HD testing at Rush. Thankful for that. She knows how to find that on our MyChart system. But nowadays, I know genetic counselors that do order the genetic testing as well. Genetic counseling is, of course, involved in the process. The laboratory extracts DNA from the white blood cells. The test counts the number of repeats in each gene copy. And then the final result is reported with two numbers, because, again, we get one from mom, one from dad. Diagnostic versus pre-symptomatic testing really just describes if someone has symptoms or not at the time that they're being tested, right? So diagnostic testing can be a little bit more straightforward, can still have psychosocial implications with regards to mental, emotional, psychological counseling that's needed. Pre-symptomatic testing is for individuals who don't have symptoms at the time of being tested, but may be at risk of developing symptoms based on family history. Very likely to have psychosocial implications here, and we definitely want to follow the HDSA testing protocol here, where we want to, encourage them to meet with a genetic counselor, neurologist, have a mental health assessment, and that'll involve pre-test, post-test results disclosure, lots of follow-up. A major component to know is that we can't prevent or predict HD, and this applies to many adult onset conditions, but the genetic test results themselves come with a lot of uncertainty in terms of age of onset, onset of symptoms, disease progression. Again, I'm going to go through this a little bit more quickly, but this kind of just shows the DNA expansions, the CAG repeat expansion here that causes an expanded protein. Have most of us seen the breakdown of these CAG sizes? Hopefully those of us that have met with a genetic counselor recognize this. Again, I'm going to go through these a little bit more quickly, but normal sizes are defined as less than 27. That means you will not develop Huntington's if both of your two repeat sizes on your test report are less than 27. Intermediate alleles are 27 to 35 and usually don't cause Huntington's symptoms, but are considered to be unstable when passing down to children. So this is where that anticipation, the instability with regards to the number growing bigger from parent to child starts to become an issue, is starting at 27 to 35, but continues through to the upper ranges as well. These bottom two areas, reduced penetrance and full penetrance alleles, which are 36 to 39 and then 40 and above respectively. This is when we can start seeing Huntington's. Generally, reduced penetrance means that you may or may not see symptoms in an average lifetime, but generally, if you do see symptoms, it'll probably show up at an older age than someone who has a higher repeat size in the full penetrance, the 40 or above range. So someone who has a repeat size that's 40 or more probably is going to see Huntington's symptoms, again, most often starting in their 30s or 40s, but there's a lot of variation there. There's definitely people that show up with symptoms at a much younger age and also much older ages as well. So let's talk about reproductive options, because this whole time I was working up to talk about family planning here. We have a couple of different biological genetic testing options for people that are trying to plan for having children when they know they either have or may be at risk of having a genetic mutation in the Huntington's gene. One is through prenatal testing, and yeah, actually, I'm going to skip past the slide just because we're kind of running short on time. But a couple options here include chorionic villus sampling, which occurs at 10 to 13 weeks of gestation and involves sampling some of the developing placental tissue. Another option is waiting until about 15 plus weeks of gestation. Typically, we don't perform this past 20 weeks of gestation just to give the genetic test enough time to run and come back with results. So amniocentesis is this other option that usually occurs between 15 and 20 weeks, but sometimes there's a little bit of wiggle room there. And that involves sampling some of the amniotic fluid from the amniotic sac. This can give us a gene positive or gene negative result for the Huntington's gene in terms of the mutation being present or absent in the pregnancy. Some of the pros of prenatal testing through both of these, again, the CVS, chorionic villus sampling, and the amniocentesis method. It certainly greatly reduces the risk of passing on disease. There's always a little margin of error, right? It's also a natural pregnancy, quote unquote, and there's a biological relationship between the parent and the offspring. Some cons may include that there can, in some cases, be ethical considerations with regards to pregnancy termination. This can be a difficult decision for a lot of people to be faced with, right? And this is why we usually say about these two options, we would only recommend considering these if the parents know that they would be open to a pregnancy termination if the result were to come back positive. Another major ethical guideline around Huntington's testing is that we don't test children for Huntington's because we don't currently have a cure, right? So there's no reason to saddle a child with that emotional burden, open them up to genetic discrimination right now. So we say no reason to test children under the age of 18. And if at all possible, try to avoid bringing a potential future human child into the world knowing that they're gene positive. Costs will also vary here. Sometimes prenatal testing can be pretty much entirely covered by insurance, but insurance is also kind of an uncertainty for a lot of us, right? The procedure does carry a small risk of miscarriage because this is considered an invasive procedure. Essentially, we have to take a needle to extract either the placental tissue or the amniotic fluid. So with that invasive procedure, there is a minor risk of miscarriage. And in some cases, if the at-risk parent has not been tested, I think this is maybe less common, but we could reveal the status of the at-risk parent if the pregnancy tests positive, right? It would sort of be a diagnosis for the at-risk parent as well. Adoption is also a family planning option that I'll say it doesn't have as much to do with genetics, of course, right? But this is a pedigree that shows the brackets at the bottom right there represent individuals who have been adopted into a family. So adoption, some of the pros, of course, include that it eliminates the risk of passing on Huntington's disease. It can also help a child, family, or a mother in need, right? It can be very expensive on the flip side. I would say $20,000 might even be a lower estimate nowadays, but it can be a long process. There's no biological relationship to the child, of course, which for some people may not necessarily be a con. But then there's also possible long-term sequelae of adoption, just in terms of, there's unique psychosocial considerations to take into account when adopting a child. We can also think about egg and sperm donors. So probably speaks for itself, but the D's on the left and right side represent donors that are contributing either a sperm or an egg on the right side, respectively, to a pregnancy. This eliminates the risk of passing on Huntington's disease because we're obtaining a gamete from someone who does not have the Huntington's gene mutation in their family. This may involve several processes that can include IVF, in vitro fertilization, artificial insemination, egg donor surrogacy, and costs will also vary here. So typically it will be a lot more expensive for donor eggs versus donor sperm, but these costs can also, again, vary from, I think, clinic to clinic. And of course, there's no biological relationship to the parent for the at-risk or affected parent here. PGD or PGT, as it's also known, stands for pre-implantation genetic diagnosis or pre-implantation genetic testing. It's a method of screening embryos for a known genetic condition, and this applies to Huntington's, a lot of other conditions as well. We can do this for chromosomal conditions. The list, again, goes on and on nowadays, but this must be performed in conjunction with IVF. So it literally means fertilization in a glass, in vitro. Historically, we sometimes refer to these procedures, these babies, as test tube babies, and IVF is often used in conjunction then with PGT, the testing itself. I'm going to go through these a little bit more quickly here, but yeah, just some considerations for IVF with the pre-implantation genetic testing of embryos. It can significantly reduce the risk of passing on disease. Non-disclosure testing is available as well. So if the at-risk parent says, I really don't want to know my status, I don't want to find out if I have Huntington's or not, I just want to have a gene negative, quote unquote, healthy child, there are laboratories that will do the testing on embryos and not tell the parents whether there was a gene positive embryo or not. They'll perform the procedure and no one has to know about the parent's status. This can, for some people, reduce the guilt of, this is a complicated matter from a psychosocial standpoint for genetic counseling as well. But, some families may feel guilt about the risk of passing on Huntington's. There's no increased risk of birth defects, which is, I would say, also a pro with PGT IVF. There's a biological relationship. And this is an acceptable option for at-risk couples that would not want to consider terminating a pregnancy, potentially with prenatal testing. Some of the cons are that it can be considered experimental. The maximum accuracy is about 98%, which I would still consider high, but no test is 100% perfect. There can be DNA contamination in some cases. I think this is rare, but from the gametes, like from the egg or the sperm, for example, that does not represent the embryonic DNA. And the testing process can fail in some cases. There's also emotional and ethical considerations, discarding embryos that could, in theory, lead to healthy, productive lives. That might be a consideration for some people, not for all, but some people might take that into account from an emotional or ethical standpoint. The take-home baby rate, I'm going to talk about that in a minute. We can't predict the future. Again, there's a lot of uncertainty with any given family planning method, but there's a risk of, with prenatal testing of multiple births, sometimes because we're taking multiple embryos for implantation, there's a higher rate of twin pregnancies. This may also involve several processes. So a lot of times the success versus failure rate is going to be relatively on the lower side. We may have to go through this process a few times over, and it can be expensive. Insurance coverage does vary. Here's some statistics. I'll let you guys read this. I'm going to go through this a little bit more quickly here, but just about the again, take-home baby rate, basically the success of IVF resulting in a viable, successful pregnancy. Financially, this also varies as well. Again, IVF cycles out of pocket when there's no coverage can range from $16,000 to $18,000. And again, that might even be a little bit outdated at this point. I want to say it might be a little bit higher than that, unfortunately. Drugs, the drugs that we have to use to stimulate the process of ovulation are also in the realm of $3,000 to $5,000. Donor eggs can be, again, $8,500. Donor sperm, $500. The PGT cycle or testing per cycle can add an additional $2,500 to $6,000 as well. And more than one cycle is oftentimes necessary, just given the relatively lower rate of success with IVF. So this can create an economic barrier. Currently, there are 15 out of our 50 states that have laws requiring coverage, and Illinois is one of those states. 8 states actually mandate coverage of IVF, in fact, and that being said, there's a lot of particular restrictions in terms of sometimes age of the parent, number of IVF attempts. So even though it's great that there are some states that have coverage, there are also some unfortunately limiting restrictions there as well. I'm going to skip past this too. Just a couple of quick family stories. So just some things to consider. I want to say there's no right or wrong answers here, but just some things that we think about from a genetic counseling standpoint in family planning. Say we have a 25-year-old pregnant woman seeking genetic counseling because her partner is at risk for Huntington's. She wants prenatal diagnosis, so either the CVS, the embryonic, or sorry, not embryonic, the CVS chorionic villus sampling or the amniocentesis. Her partner's 27, has not been tested, and he says he doesn't want to know his HD status. He's not ready to get the testing yet, maybe, right? So we think about what are these issues? The couple's disagreement, right? There may be pressure from both sides of the family. Who is the patient here, right? Is it the pregnant woman? Is it her partner? Is it the potential future baby here? There's a lot of questions to discuss, and this is where I might loop in some cases, our social worker, our neuropsychologist, and ethics board in some cases. These can be really tricky and tough conversations to have. With adoption, say we have a couple who's at risk for HD, the husband has tested gene positive, and they still want to start a family, so they're considering adoption. Some of the issues we might consider might include facing a future with HD for the parent, right? For the husband who is likely to develop symptoms in the future. There's also no guarantee of any child having 2 healthy parents, right? With or without Huntington's, right? That's never a guarantee, but it is something that we know that if one of the parents is gene positive, that's going to result in symptoms at some point in that parent's lifetime. And also, will the adoption agency ask about the parent's health? Sometimes this might need to be a point of consideration that they may care to know that one of the parents will develop Huntington's disease. Another case of where we may have an asymptomatic parent, say we have a 28-year-old who wants to know her gene status for family planning purposes. Her 45-year-old mother, though, has not been tested and doesn't want to know her genetic status. So it's sort of a mystery as to whether the mother has even inherited the genetic mutation. If she did, there would be a 50-50 chance of passing it down to the 28-year-old, right? If she didn't, there would actually be a 0 chance of it passing down, but we don't know this yet. So some of these issues might include testing the daughter could, of course, reveal the mom's status. It could sort of be a double diagnosis for both the daughter and the mom at the same time. If there's disagreement between the two of them about how they do or do not want to receive this information, right? Right to information, right? Is the daughter within her rights to get tested? I would say the short answer there is yes, but a lot of complicated psychosocial considerations to navigate there. Also, keeping health information from family members. Sometimes we might want to talk about a plan of who are we going to share this information with versus who are we going to not share this information with. These can be difficult conversations to have with our family members, and even knowing how to, navigate just the dynamics in a family of how health information is or is not shared with your relatives. This can be really tricky stuff. And from there, just how to proceed. No right answers here. Again, these are not simple questions to answer, but some things to consider. We must have a confirmed family mutation for some of these family planning options. PGD can have implications for family members' risks. We can undergo IVF with PGD without learning someone's status. So that's the non-disclosure, the sort of blinded PGT IVF. There's no such thing as risk-free, but reproductive options do exist for families with Huntington's. And there are lots of complex issues involved. So definitely seek help from qualified professionals, genetic counselors, neurologists, psychiatrists, neuropsychologists, social workers, all of us. Identify your support system too, right? These are very important. And some take-home messages just to consider. We already know HD is an autosomal dominantly inherited condition. Family planning options do exist for individuals who want to reduce the risk of passing the condition Huntington's onto their children. Each method has its own unique pros and cons. And so one method is not going to be the right choice for every single person. It's not a one size fits all, right? For some people, there may be an option that's perfect for them. It may not be perfect for someone else in their own family, right? Affected and at-risk individuals can and do, I will say, benefit from genetic counseling. So please see a genetic counselor. And genetic counseling can answer a lot of questions and address options for testing, family planning, and research participation.